Green Top Guideline Number 12. Pregnancy and Breast Cancer. Introduction and Background. Breast cancer is the most common cancer in the UK, accounting for 15% of all new cancer cases. There are around 56,800 new breast cancer cases in the UK every year. Of these, 9% occur in women at or under 44 years of age. In women diagnosed under the age of 39 years, 85% are alive more than 5 years after their diagnosis. A new breast cancer diagnosis complicates about 1 in 3,000 pregnancies. The 2021 Brace report states that clinicians should treat women who may become pregnant, are pregnant, or who have recently been pregnant the same as a non-pregnant person unless there is a very clear reason not to. For pregnant women with breast cancer, a care plan should first be established by surgeons and oncologists, as if the woman was not pregnant. This plan can then be adapted with a multidisciplinary team that should also include obstetricians, fetal and neonatal specialists. This team should balance potential treatment for the woman and her fetus with potential compromise for pregnancy outcome. These treatment options must be discussed with the woman. MDTs may need to consider treatment which is in the best interest for the woman. Pregnancy is not, however, an exception to the principle that an informed patient has the right to refuse treatment, even treatment needed to maintain life, and a pregnant woman's informed decision to refuse recommended medical or surgical interventions for breast cancer should be respected. How should women who have breast cancer diagnosed during pregnancy be cared for? Prognosis of breast cancer diagnosed during pregnancy and postpartum. Historically, breast cancers diagnosed during pregnancy or in the first few postpartum years following birth have been combined under the heading of PABC. However, data suggests that breast cancer diagnosed during pregnancy has differing tumor biology and clinical outcomes when compared with breast cancer diagnosed in the postpartum period, and that this distinction can last for 5 to 10 years following birth. Also, there is increasing evidence that breast cancer prognosis differs between breast cancer diagnosed during pregnancy, PRBC, and breast cancer diagnosed in the months postpartum, PPBC. Therefore, there are calls to consider PRBC as a distinct entity from breast cancer diagnosed in the 5 to 10 years following birth, PPBC. Breast cancer diagnosed during pregnancy, PRBC. A large study, comparing histopathological profiles of women with PRBC with age-matched non-PRBC women, confirmed that women with PRBC have tumors with a more aggressive phenotype than non-pregnant counterpart. However, when matched for tumor stage, the outcome for women with PRBC is similar to non-pregnant controls. By using diagnostic and treatment pathways for women with PRBC which are as close as possible to women with non-PRBC, similar outcomes can be achieved. Breast cancer diagnosed in the postpartum period, PPBC. Compared to with women diagnosed with breast cancer during pregnancy or nulliparous women, PPBC is associated with worse survival rates and more than double the risk of metastatic disease, higher rates of lymph node positivity, and higher grade disease. The pathogenesis for this worsened prognosis is thought to be linked to the shift of mammary gland epithelium from a state of proliferation and differentiation to involution, and persistence of promalignant cytokines and altered immune infiltration for several years following birth. In a cohort of women with estrogen receptor-positive PPBC, metastasis-free survival was similar to that seen in estrogen receptor-negative nulliparous women. What is the optimal care of women with breast cancer diagnosed during pregnancy? Diagnosis and radiological investigations. Any suspicious breast lesion or lump which is present for more than 7 days should be urgently referred to a specialist unit with the patient seen and diagnosed within the National Faster Diagnosis Standard 28-day timeframe. Suspicious breast lesions should be investigated by ultrasonography to allow a targeted biopsy. It will permit rapid differentiation between benign and malignant lesions. Breast ultrasound has the highest sensitivity for the diagnosis of PRBC and is the first-line imaging examination. Mammography should be reserved for investigation of extent of a known cancer. However, in pregnancy, it may be indicated in the presence of suspected false negative ultrasound scan or suggestion of malignancy on the ultrasound. Fetal radiation exposure during mammography is between 0.001 and 0.01 mg. Lead apron shielding will further reduce fetal exposure by 50%. Once an underlying malignancy is proven, mammography with percutaneous biopsy will characterize tumor extent and presence or absence of associated malignant microcalcification. Digital breast tomosynthesis acquires a series of images by passage of the X-ray tube across a limited arc above the breast. Although digital breast tomosynthesis incurs a very slightly higher radiation dose to the fetus, it offers sensitivity and specificity in the dense breast tissue of pregnant women. Suspicious breast lesions, clinically or on imaging, should be investigated by image-guided core biopsy and not solely fine needle aspirate cytology. Core biopsy is more accurate, informative, and can help treatment planning if malignant. Suspicious axillary lesions, clinically or on imaging, should be investigated by image-guided core biopsy or fine needle aspirate cytology. Preoperative axillary staging is essential for treatment planning. Non-contrast or diffusion-weighted imaging magnetic resonance imaging scans are safe during pregnancy and can be used when indicated. MRI scanning may contribute to surgical planning and staging information. Contrast-enhanced MRI scanning should be avoided with the exception of situations where the benefits will clearly outweigh the risks. PET-CT can be used with caution if the MDT feels that information gain may change management, and providing this information cannot be obtained by non-ionizing imaging modalities. Following maternal administration of a typical PET-CT dose of 250 mbq-18 fluorodeoxyglucose DG, fetal exposure is between 10 and 20 mgy. The maternal urinary bladder is the primary contributor to fetal radiation dose, and good maternal hydration with encouragement of early voiding or catheterization can help minimize radiation exposure. Micturition 1 hour post-administration reduces fetal exposure by up to 45%. CT scanning may potentially be considered in the presence of suspected metastatic disease. The radiation dose to the fetus is critical in deciding the appropriateness of CT scans in the pregnant woman. Scanning of the head, chest, or abdomen or pelvis results in markedly differing fetal radiation doses. Shielding of the abdomen with lead aprons does not substantially reduce fetal exposure to ionizing radiation. CT scanning of the abdomen or pelvis in pregnancy should be avoided if possible, but if it is considered necessary, discussing versus the risks with the mother is important. Surgery, approach, and considerations. Women diagnosed with breast cancer during pregnancy should be under the care of a dedicated multidisciplinary team, which has the expertise and experience to manage all aspects of maternal and fetal health. A specialized pregnancy-associated breast cancer multidisciplinary team includes the oncology team members, an obstetrician, an obstetric physician, an anesthetist, and, where necessary, a neonatologist. Breast surgery can be performed throughout pregnancy with appropriate fetal monitoring prior to and following surgery. Any decision to delay surgery until the second trimester should be balanced against the risk of leaving the cancer in situ, as well as any consequent delays to chemotherapy. Breast cancer, surgery, and pregnancy itself are all risk factors for thrombosis. Thromboprophylaxis with low molecular weight heparin or equivalent should be administered in accordance with guidelines. Positioning the woman in the left lateral tilt will reduce aortic valve compression. Breast surgical choices should be the same as for non-pregnant women, with the exception that reconstructive procedures, where required, should be performed postpartum. Breast cancer surgery should be guided by tumor biology and the woman's choice. For early-stage breast cancer, breast-conserving surgery with a wide local excision followed by radiotherapy is as effective as mastectomy, provided the margins of the resected specimen are free of tumor. However, radiotherapy is challenging to deliver during pregnancy. Women should be advised regarding the implications of any delay to radiotherapy if this is not given during pregnancy. Some women may choose to undergo a mastectomy to avoid these issues. For the vast majority of women diagnosed in pregnancy, neoadjuvant or adjuvant chemotherapy will be indicated, and radiotherapy can be safely delayed until postpartum. Tissue expander reconstruction has successful aesthetic, maternal, and fetal outcomes. Operative time is increased when immediate reconstruction is undertaken. Wound complications following reconstruction can be expected to be higher and could potentially delay commencement of systemic therapy. People who are pregnant and contemplating immediate reconstruction following mastectomy should be fully informed of the lack of data available to provide evidence-based recommendations. Furthermore, physical changes in the breast during the shift from pregnant to postpartum state may significantly exaggerate any asymmetry between the reconstruction and contralateral breast, leading to poorer long-term cosmetic outcomes. Sentinel node localization should be performed with technetium-99m labeled radiocolloid injected on the day of surgery. Isosulfan blue, patent blue, or methylene blue dye should not be used during pregnancy for axillary staging. They may cause allergic or anaphylactic reactions. Women with biopsy-proven axillary metastases should receive a recommendation for axillary node clearance. Sentinel node surgery is the standard of care for women with clinically node-negative pregnancy-associated breast cancer. Fetal radiation exposure can be further minimized by same-day radioactive tracer injection, thereby reducing time between injection and surgery. Accuracy of and local recurrence rates following sentinel node surgery in pregnancy-associated breast cancer are similar to those seen in non-pregnant women. Systemic therapy during pregnancy. When discussing the potential impact of any medication administered during pregnancy, it is important to discuss this within the context of a background incidence of major congenital malformations of 2 to 3%, miscarriage of 10 to 20%, and stillbirth of around 0.5%. Chemotherapy. Chemotherapy is contraindicated during the first trimester of pregnancy, but can be administered during the second and third trimesters. Chemotherapy administered during the first trimester is associated with a significantly increased risk of fetal malformation. Chemotherapy should not be given beyond 35 weeks of pregnancy, or within 2 weeks of anticipated birth if this is earlier, with the exception of less myelosuppressive weekly regimens that can be continued longer at the discretion of the treating oncologist. Chemotherapy has a myelosuppressive effect on both the woman and the fetus, and therefore adequate time for bone marrow recovery prior to birth is advisable to reduce the risk of infection. Choose the treatment strategy according to local guidelines for a non-pregnant woman according to the pathology and tumor characteristics wherever possible. The majority of chemotherapy agents used in the management of breast cancer can be safely given adjuvantly or neoadjuvantly in the second and third trimesters of pregnancy, and the regimen which offers the best maternal outcome should be used. Anthracyclines, cyclophosphamide, taxanes, and carboplatin are the preferred chemotherapy agents in the treatment of pregnant women with breast cancer. These agents are considered optimal in the treatment of breast cancer, especially in stage 1 to 3 disease, and have been demonstrated to be safe to administer during pregnancy. Paclitaxel may be the preferable taxane regimen in pregnancy as it is less myelosuppressive, with a lower risk of complications should unexpected early birth occur. Nab-paclitaxel is predominantly used in women who have had hypersensitivity reactions to taxanes. Carboplatin has been added to the regimes in the neoadjuvant treatment of triple-negative breast cancer, tumors that lack receptors for estrogen, progesterone, and HER2, with demonstrated improvements in pathological complete response rate. 5-fluorouracil should be omitted in early breast cancer. Capecitabine, the oral prodrug of 5-fluorouracil, could be considered for the treatment of advanced disease. Older regimes such as CMF have inferior efficacy compared with anthracycline and taxane combinations. CMF should be avoided in pregnancy. Dosing of chemotherapy should be based on the woman's actual weight, not the pre-pregnancy weight. The woman should be reweighed and doses recalculated at each cycle of treatment. Pharmacokinetics of chemotherapeutic agents are altered in pregnancy. Dosing on pre-pregnancy weight may lead to underdosing and reduced efficacy. Chemotherapy is dosed on body weight, with the exception of carboplatin that is dosed on renal function. The use of dose-dense chemotherapy regimens, where the interval between successive treatments is reduced compared with a standard regimen, is increasing in the treatment of early breast cancer, particularly for women with a higher risk of recurrence. This involves reducing the interval between chemotherapy regimens with the use of granulocyte colony stimulating factor support, and could be a useful strategy to ensure completion of chemotherapy prior to birth. Intensified DD regimens, using a higher dose over a shorter period of time, is not recommended in pregnancy. Exposure to chemotherapy in utero may be associated with fetal growth restriction. The highest rates of FGR were with platinum-based chemotherapy exposure. Because of potential adverse effects on fetal growth, women undergoing chemotherapy should receive additional monitoring for fetal growth. Endocrine therapy. Defer the administration of endocrine therapy until after birth. Fetal malformations have been reported following tamoxifen and aromatase inhibitor exposure in utero. Tamoxifen is indicated in the treatment of ER+ breast cancer for both early and advanced disease. A literature review reported anomalous fetal development in 12.6%. The reported malformations were facial malformations and anomalies in the infant female external genitalia. Targeted therapies. Where possible, the administration of HER2-directed therapy should be delayed until after birth. If HER2-directed therapy is required for the management of life-threatening metastatic disease, individualized monitoring of the woman and fetus is recommended. Trastuzumab administration is associated with a significant risk of oligohydramnios and anhydramnios and consequently fetal toxicity. Inadvertent trastuzumab exposure during the first trimester is not an indication for termination. If HER2-directed therapy is required for the management of life-threatening metastatic disease, twice-weekly fetal scans to assess amniotic fluid volume and fetal well-being with umbilical artery Doppler measurements should be arranged. Bone-modifying therapy. Consider bone-modifying treatment to pregnant women with metastatic disease only where the maternal need outweighs the risk to the fetus, for example, uncontrolled hypercalcemia or significant bone pain. Where exposure to bisphosphonates has occurred, either prior to or during pregnancy, fetal growth and skeletal development should be monitored. Mother and infant should also be monitored for hypocalcemia. Supportive therapy. Antiemetics including 5-HT3 antagonists, cyclizine, prochlorperazine, metoclopramide, domperidone, and olanzapine may be used as indicated in line with standard protocols. Aprepitant may be used in line with standard protocols where a neurokinin-1 antagonist is indicated. Optimal management of anticipated or actual treatment-related toxicity is essential to improve patient tolerability and adherence. These agents have been demonstrated as safe to use during pregnancy. Methylprednisolone or hydrocortisone should be used in place of dexamethasone. Corticosteroids reduce chemotherapy-induced nausea and vomiting and treatment-associated hypersensitivity reactions. Corticosteroids generally have been demonstrated as safe to use during pregnancy. These specific agents are more extensively metabolized in the placenta than dexamethasone, thus minimizing fetal exposure. G-CSF should be used as indicated in line with standard protocols. Prevention of febrile neutropenia is paramount to minimize maternal toxicity and optimize treatment intensity. G-CSF has been demonstrated as safe to use during pregnancy. H2 receptor antagonists may be used where required to prevent administration-associated hypersensitivity reactions. Prevention of treatment-associated hypersensitivity reactions is imperative to minimize maternal toxicity and optimize treatment intensity. H2 antagonists have been demonstrated as safe to use during pregnancy. Antihistamines may be administered where required. Antihistamines have been demonstrated as safe to use during pregnancy. Seek Pharmacist of Medicines Information Centre acts a UK Medicines Information Drugs in Pregnancy Special Advisory Service for advice on any other medication indicated that is not covered by this guideline. Therapeutic radiation during pregnancy. Where a delay in radiotherapy is not expected to adversely impact maternal outcome, it is recommended that adjuvant breast or chest wall radiotherapy is postponed until after the birth of the baby. Adjuvant radiotherapy can be considered in specific circumstances, i.e. if risk from omission or delay outweighs harm to the fetus, provided that this is achievable within safe limits of radiation exposure to the fetus, i.e. below the deterministic threshold. Referral to a specialist center with suitable expertise should be considered. The option of mastectomy versus breast-conserving surgery may be considered if the former will allow omission of or avoid unacceptable delay in radiotherapy. Randomized studies have shown equivalent outcomes for breast cancer recurrence and survival with breast-conserving surgery and radiotherapy versus mastectomy. If the woman is unexpectedly discovered to be pregnant during radiotherapy, they should be informed of the individual risks so that they can make an informed choice regarding continuation of the pregnancy. The possible effects of radiation include fetal death in the first 2 weeks post-conception, congenital malformations up to 8 weeks, and the highest risk of neurodevelopmentally delay between 8 and 15 weeks of pregnancy. In the metastatic setting, palliative radiotherapy may be indicated for local control of symptomatic disease or to preserve function, e.g. metastatic spinal cord compression. Termination of pregnancy. Women diagnosed with breast cancer during pregnancy should have all treatment options discussed and the implications of terminating or continuing with their pregnancy to allow informed decision-making. Care during pregnancy. Women with PRBC can be reassured that their breast cancer can be treated during pregnancy without long-term harm to their unborn child. Women with PRBC should have monitoring to identify FGR from 28 plus 0 weeks of gestation and thereafter according to clinical need. Iatrogenic preterm birth should be avoided unless there are clear maternal or fetal indications. Studies showed that impaired cognitive development was associated with iatrogenic preterm childbirth, but not breast cancer or its treatment. In the absence of established lymphedema, in women who have had any previous axillary surgery medical procedures, including blood tests, cannulation, and blood pressure measurements, can be performed on the side of surgery if the contralateral arm is unsuitable for use. There is no evidence that medical procedures on the surgical side increase the risk of lymphedema. Timing of birth. A date for birth should be jointly planned by the MDT and the woman. This date should be kept under review and adjusted according to maternal and fetal well-being. Women with breast cancer should aim to give birth at term, after 37 plus 0 weeks. If preterm birth is indicated, corticosteroids for fetal lung maturation can be given as usual in addition to previously administered steroids given with chemotherapy. Birth should be planned a minimum of 2 to 3 weeks after the last dose of chemotherapy to reduce the risk of fetal and maternal myelosuppression. Metastatic breast cancer diagnosed during pregnancy. For women with metastatic breast cancer requiring palliative care, late preterm birth, 34 to 37 weeks, may be discussed. Long-term pediatric outcomes after a maternal diagnosis of breast cancer during pregnancy. Women undergoing treatment for breast cancer during pregnancy should be reassured that pediatric outcomes after maternal treatment for cancer in pregnancy are good. Newborns exposed to platinum agents in utero should undergo the automated auditory brainstem response test in addition to the automated otoacoustic emission test. Children exposed to platinum agents risk ototoxicity, which may not be identified by otoacoustic emission testing. Future fertility considerations. Impact of systemic therapy for breast cancer on fertility. Women of childbearing potential with a new diagnosis of breast cancer should be counseled, at diagnosis, about the potential impact of systemic therapy on their future fertility. Chemotherapy reduces ovarian reserve, whereas endocrine therapy indirectly impairs fertility because of the time on treatment. Women with breast cancer need to make informed decisions about both fertility preservation and systemic therapy choices. Fertility preservation after a diagnosis of breast cancer. The likelihood of women achieving a first pregnancy after a diagnosis of breast cancer is approximately 40% lower than those without disease. This is partly explained by chemotherapy-induced gonadotoxicity following treatment with alkylating agents such as cyclophosphamide, and partly because of reduced ovarian reserve in women over 35 years. However, it may also be because of the reluctance of women and their clinicians to consider a pregnancy after breast cancer, wrongly believing that pregnancy may adversely affect prognosis. Cryopreservation. At diagnosis, the impact of breast cancer diagnosis and its treatment on future fertility should be discussed between the affected woman, their cancer team, and the reproductive medicine service, who should take into account maternal age, treatment plan, prognosis of the cancer, and expected outcome of subsequent fertility treatment. Input from multiple specialists will provide women with information for informed decision-making. All women who have not completed their family should, at diagnosis, be offered the opportunity to meet with a reproductive medicine specialist. Women of reproductive age who are being considered for medical treatment for breast cancer that may cause premature ovarian insufficiency should be offered oocyte or embryo cryopreservation as appropriate. There is substantial evidence outside of oncology that this is the optimal way to maximize future fertility. What is the role of gonadotropin-releasing hormone analogs as fertility preservation during chemotherapy? Premenopausal women undergoing chemotherapy for breast cancer and who are interested in fertility preservation should be offered temporary ovarian suppression with a gonadotropin-releasing hormone agonist during their chemotherapy. Fertility preservation with GnRH agonists should commence, where possible, at least 1 week prior to the first dose of chemotherapy and continue for the duration of treatment. Fertility preservation with GnRH agonists should not be offered as an alternative to oocyte or embryo cryopreservation, but should be offered to all regardless of whether or not they are having oocyte embryo cryopreservation. Oocyte or embryo cryopreservation remains the most effective option for fertility preservation. Contraception after a diagnosis of breast cancer. Women undergoing systemic therapy for breast cancer should be advised to use contraception. All systemic therapy for breast cancer is contraindicated prior to conception and in the first trimester because of the risk of fetal anomalies. Women who have a history of breast cancer should be advised to use non-hormonal contraception. Hormonal-based contraception may increase the risk of recurrence, and non-hormonal approaches should be used if at all possible. Women who have a history of breast cancer who require emergency contraception can be offered hormonal contraception. A single dose of hormones is very unlikely to have any effect on breast cancer recurrence. Hormonal contraception and the risk of breast cancer. Women who currently or have recently used hormonal contraceptives have been shown to be at increased risk of breast cancer, rising with each year of use. The absolute risk was 1 extra case of breast cancer for every 7,690 women who used hormonal contraception for 1 year. The levonorgestrel intrauterine system is also associated with a higher risk of breast cancer. Contraception after breast cancer. The ideal contraception for women with breast cancer is non-hormonal. Safe options include the copper intrauterine device. The risk of infection associated with chemotherapy is not a contraindication to use of the copper IUD. Other contraceptive options include 2 simultaneous forms of barrier contraceptive, or if future pregnancy is not desired, sterilization of the woman or her partner. There is insufficient evidence to confirm that the levonorgestrel intrauterine system is safe after a previous diagnosis of breast cancer, even in women with an ER-negative cancer, who may be at risk of a new ER-positive cancer. For the rare circumstance where there are no suitable non-hormonal options, input from the women's breast specialist team should be sought prior to use of a progestogen intrauterine device. Preimplantation genetic diagnosis for familial breast cancer. Women who carry pathogenic genes associated with breast cancer should be offered preimplantation genetic testing for a monogenic disorder, PGTM, following counseling about the IVF process and likelihood of a successful pregnancy outcome. What are the considerations for subsequent pregnancies after a diagnosis of breast cancer? Impact of pregnancy on breast cancer. Women with a history of early breast cancer who wish to become pregnant should be advised that pregnancy does not increase their risk of breast cancer recurrence. Interruption of endocrine and other targeted therapy. Women planning a pregnancy who are taking adjuvant tamoxifen must discontinue treatment at least 2 months before attempting to conceive for adequate washout of tamoxifen and its active metabolites. Any woman receiving endocrine or other targeted therapy and planning a pregnancy should be referred to their oncologist for a discussion regarding their proposed treatment break. Assisted reproduction after treatment for breast cancer. UK and international guidelines recommend fertility preservation at diagnosis prior to starting anti-cancer therapy for all women who have not completed their family. None of the studies showed any detrimental effect on breast cancer recurrences in the women undergoing ART after completion of treatment for breast cancer. What is the optimal care in pregnancy following treatment for breast cancer? Pregnant women who have been treated for breast cancer can be reassured that pregnancy will not adversely affect their disease-free survival. Evidence from mainly retrospective case series shows that pregnancy following a diagnosis of breast cancer does not reduce overall or disease-free survival. Pregnant women who have had chemotherapy for breast cancer should have additional fetal growth scans from 28 weeks and thereafter according to clinical need to identify an increased risk of FGR. Women who have received chemotherapy have an increased risk of small 4 gestational age babies. Women who had treatment-related left ventricular dysfunction, LVD, are at risk of heart failure during pregnancy and should be referred for cardiology assessment pre-pregnancy or as soon as possible during pregnancy. Approximately 30% of women who have chemotherapy-induced cardiotoxicity develop peripartum heart failure. Women with no history of treatment-related LVD are at low risk of pregnancy-related heart failure and should be offered an echocardiogram to assess left ventricular function. Women with subclinical heart failure are at risk of becoming symptomatic from 26 plus 0 weeks of gestation when cardiac output is maximum. A meta-analysis that included women who became pregnant after a diagnosis of breast cancer showed a greater risk of low birth weight, odds ratio 1.50, preterm birth, odds ratio 1.45, small 4 gestational age, odds ratio 1.16. These adverse pregnancy outcomes were more common among women who had received chemotherapy. Following a diagnosis of breast cancer, women were also more likely to have a cesarean birth, but adverse pregnancy outcomes including risk of miscarriage, fetal anomaly, preeclampsia, and peripartum hemorrhage were similar to those of women without previous breast cancer. Anthracycline-induced cardiotoxicity is also dose-dependent and unlikely to develop in those who receive low-dose doxorubicin. If it does manifest, almost all cases of cardiotoxicity present within 12 months of treatment. An attenuated gestational increase in cardiac output may also explain the increased risk of FGR and peripartum heart failure following chemotherapy. Breastfeeding during and after treatment for breast cancer. Women taking tamoxifen should be advised not to breastfeed. Studies show harmful effects on urogenital tract development. Clinically significant levels of tamoxifen are present in human breast milk. Women receiving chemotherapy should be advised not to breastfeed. Women can continue to breastfeed following breast surgery and adjuvant irradiation if they wish to do so. Lactation from the untreated breast will be unaffected. Prevention and suppression of lactation can be achieved by administration of oral cabergoline. Cabergoline provides rapid, safe inhibition of lactation by decreasing prolactin production. Tamoxifen. Tamoxifen is a selective estrogen receptor modulator and is part of the standard of care for treatment of premenopausal women with ER+ breast cancer. Tamoxifen and its active metabolites can be found in human breast milk within 1 day of starting treatment, and levels rise until 3 weeks. Monoclonal antibodies, MABs, such as trastuzumab and pertuzumab, are large protein molecules, and it is likely only small amounts will transfer into breast milk, with partial destruction in the infant's gastrointestinal tract. The manufacturers advise breastfeeding should discontinue during therapy and for 7 months after the last dose. Diagnostic imaging by PET-CT. The International Atomic Energy Agency advised that small amounts of 18F-fluorodeoxyglucose is excreted in breast milk. Breast milk should be collected and discarded for 2 hours after the scan, following which normal breastfeeding may resume. Lactation following breast-conserving surgery and irradiation. Breast-conserving surgery to remove cancers near or at the nipple is more likely to impair breastfeeding from that breast, whereas excision of tumors more distant from the nipple-areola complex is less likely to cause an effect. The probability of a previously irradiated breast being able to produce milk depends on the delivered radiation dose. Breast-conserving surgery followed by adjuvant breast irradiation may induce anatomical distortion, which can limit nipple extension and inhibit latching of the infant to initiate lactation. Invoke histopathological changes within the breast glandular tissue that can disrupt the production and flow of milk from breast alveolar cells to the nipple. Studies showed that following radiotherapy, reduced postnatal milk production was seen in approximately half of the women. Women should be reassured that adequate nutrition for their baby can be provided by feeding from one breast alone. Inhibition of lactation. Cabergoline is a synthetic dopamine D2 agonist, acting on the anterior pituitary gland to decrease synthesis and release of prolactin and hence inhibit lactation. A dose of 1 mg of cabergoline given orally on the first day postpartum inhibits lactation within 1 day. Where breastfeeding has already commenced, milk production can be stopped by oral administration of 250 micrograms cabergoline 12-hourly for 2 days. Adverse effects include dizziness, headaches, and nausea, which occur mainly in the first 3 days after intake, but the treatment is generally well tolerated.